acquired and congenital conditions. So starting with neural tube defects. So we have talked about neural tube defects, not in detail as far as exactly what they are, but they have been mentioned. These are some of the neural tube defects. I don't remember if I gave you this graphic. So some of the neural tube defects that can occur. This is obviously why it is so important for us to be mindful of diet, folic acid, and so on, and all of the testing that we talked about in Unit 1 that can give an indication of neural tube defects. The ones that you see most often are anencephaly. So the top of the skull does not form. And there's a significant portion of the brain that's open. So lack of this part of the skull vault. The brain does not develop and as fully as it should. And when these babies are born, it is pretty much exposed. There's usually a thin membrane, but it is pretty much exposed. Those babies have a short lifespan. They have a very poor prognosis, obviously. Encephaly, the meninges herniate at the back of the neck. That's this one. You don't see that as often, but I would say anencephaly, and then the spina bifida, spectrum of spina bifida is pretty much what you will see most often. So I've mentioned before that spina bifida occulta, you cannot see this from the outside, but this is one of the reasons that we examine every newborn baby's back for their lower spine and sacral area to make sure the skin is intact. Are there any sinuses, any dimples, any hair tufts, any alterations or changes in skin color, blotchiness, complexion, any of that sort of thing, because that can be an indication of spina bifida occulta. Now, it is asymptomatic, and most people with spina bifida occulta don't even know they have it because it does not impact their mobility. We looked at a baby with meningocele, and then there is myelomeningocele. And as I mentioned, you will talk more about these specifically when you go to peds, because that's where the bulk of the care is managed. For us, the babies are born, we make sure that they are stable, we take care of their cardiorespiratory status, make sure that the sac is carefully cared for. But these babies will start, they tend to have a series of surgeries, and that series starts pretty early on. So you'll follow that through in pediatrics.
Question. On the ultrasound, we are able to see these malformations, especially the meninges.
Certainly, these at the top, all of these, and all of these at the bottom, except spina bifida occulta, you might not be able to see, depending on how detailed the ultrasound is.
So you
might not be able to see this because it is enclosed. So it's quite enclosed, so you might not be able to see that.
So it's a choice of the parents to keep the pregnancy. How far along you can notice this malformation?
So the thing is that when you're able to see it on the ultrasound, that is later than when, remember, we're doing our testing early on.
Yeah.
right? And so you already have an indication that this is going to be the case. So you know that an NTD exists before you know the specifics.
Oh,
So
yeah.
sometimes parents will make a decision earlier on before they even know whether this is myelomeningocele or meningocele, and it's definitely because the fetus has not developed to that point. So this is just an explanation about the three different classes. So very often babies with, particularly with myelomeningocele, will have hydrocephalus, which I think we're going to talk about next. So babies with, come on. My PowerPoint has frozen. Okay, that's the same little one we looked at before. Okay. Congenital hydrocephalus. So again, this is a problem of the absorption. So remember, CSF, cerebrospinal fluid, is produced, absorbed, produced, absorbed. There should be a balance of that. This is a problem with the absorption, or if there's an obstruction in that flow through the ventricles. So that can cause enlargement of the head. It can cause compression of the brain. So babies with, let me show you the pictures first and then I would go back. So you can see these babies have congenital hydrocephalus. Again, the brain will expand. Remember that the sutures are not fused. The sutures of the skull are not fused, and so they will expand. So you will feel the spaces between the plates of the skull on these babies. Obviously, the fontanelles will be wide. Depending on the head shape, there may be some bulging. This baby I can see has some bulging of the fontanelle. This baby's fontanelle is flat. And you will see with these babies, there is sunsetting, what we call sunsetting of the eyes. I know this one, you can't see the full face, but you can see that there's sunsetting of the eyes. So that's what hydrocephalus looks like. So again, the ventricles are filled with CSF. It pushes the brain outward, so compression on the brain. So when these babies are born, this definitely can be seen on ultrasound. These babies, if the mom comes in and we know that this is the case, this will be an indication for cesarean birth. These moms are delivered, and then pediatric neurosurgery, neurology and neurosurgery are consulted. So these babies will need to have a shunt placed to drain the excess fluid and take the pressure off the brain. So most often we place VP shunts on these babies, so ventricle peritoneal shunts on these babies. And so the shunt is placed, it drains the CSF fluid into the peritoneum where it is absorbed. It drains that excess fluid. There is, you might not be able to, you can't see it very well, but there is a valve right about here. It's a valve usually behind the ear. You teach the parents how to check the valve to make sure that it is functional. You teach the parents how to know if the shunt is not working, the signs and symptoms of increasing intracranial pressure, so that they can bring the children in. So these children will have shunts, right? This for years. VP shunts can be placed on adults as well, because there are many things that can happen as life goes on that might require shunting. In pediatrics, again, you'll learn more about this. You'll talk a lot about this. Children with VP shunts tend to come in and out of the hospital quite a bit. The shunts need to be revised, or if they become occluded, they might need flushing and so on. So obviously, this is a very delicate procedure. It is withdrawing CSF, so it has to be a sterile procedure. And, you know, anytime you're talking about the central nervous system, neurological development, there's a lot of follow-up that's involved with these children. So,
So essentially, it's just draining the fluid to decrease the swelling, right?
no, not the swelling. It's excess central nervous, cerebral spinal fluid.
Which is getting
it's not swelling. It's CSF.
So to get rid of all this extra fluid.
Drain off the extra fluid to take the pressure off the brain tissue.
Professor, extra fluid, where do we want to drain it to?
It drains into the peritoneum.
Okay, thank you.
VA shunts are possible as well, but not as many practitioners will use a VA shunt. I mean, for safety, infection reasons, and so on. Having a shunt that drains into the peritoneum, it just presents less complications than having it drain into the atria, into the heart. So the thing is, remember, CSF is always being produced. It's always being produced. So if this is going to be a long-standing problem, typically a lot of these children have a long-standing problem with obstruction. So for instance, this baby that might have a what we call an Arnold-Chiari malformation here. This baby might have the way the brain fits into the vault. There's some descent into the top of the spinal cord. So it just doesn't drain properly. That's going to be a lifelong problem. So if a child with a malformation like this is going to need a VP shunt for life. So sometimes these conditions do require a lifelong VP shunt. Once, as they're getting older, the skull will begin to fuse. But again, there has to be this balance. They have to really be followed very closely by neurology. The parents have to know exactly how to monitor these children so that they're developing well, even with this condition. Now, let me just look at that question again. Simone, I don't know that I understand your question about neurological.
What kind of expectation we have on these kids from a learning or point of view?
It depends on. So the question is, all right, they have hydrocephalus. Do they have other anomalies? Is this a baby that also has myelomeningocele and a Chiari malformation, or is this just hydrocephalus? Because sometimes the combination is what makes it more challenging than just one thing, right? So that's the question. How much pressure has been placed on the brain? Has any alteration happened in the brain growth, in the brain tissue, in the brain development? So it's important to get these kids in to neurology and neurosurgery early, get the shunt placed as early as possible to start draining that fluid off to relieve that compression. So there's no black and white answer, honestly. It really just depends on how much pressure, if any damage is done, what other issues the child has.
Yeah.
Okay. So obviously we do head circumference. Remember when we talked about the newborn, we talked about doing the head circumference right above the, it's done just above the level of the eyebrows. So these babies, we monitor their head circumference every day to make sure that, that they're at least stable, if not gradually decreasing. And that's the other thing. You don't want a sudden decrease in the CSF, because then that means a sudden decrease in the pressure that's on the brain. The alteration can cause damage as well. So it's a gradual draining of the fluid.
Question. You made a point of the sun setting of the eyes, but what is causing that?
The pressure on the hydrocephalus, because the pressure on the head, the intracranial pressure, causes intraocular pressure. So microcephaly at the other end of the spectrum, so to speak. Microcephaly, the head circumference measures 2 or more standard deviations below the mean. So basically the brain growth is restricted. We tend to see this most with congenital viral infections. As you know, last few years, we've had problems with Zika infection. So these babies are followed up. Of course, they need lots of diagnostic evaluations. There will be developmental delays just because they don't have the brain mass. And again, the outcome and prognosis will depend on the severity of microcephaly. So as you can see with these little ones, their cranial vaults have not grown, their brains have not grown. So it's just going to depend on the extent of the growth. So microcephaly, you might have a baby that has moderate microcephaly, you can have a baby that has severe microcephaly. So obviously there will be developmental delays, cognitive delays for these children as they grow. So I mentioned lead briefly when we talked about the newborn. It is important to make sure that we're following up on this. So lead exposure can adversely affect neurodevelopment. And, you know, this might be something that you might not pay a lot of attention to, but there are major areas in this country and pretty large areas in this country that there's significant lead exposure, usually due to water contamination. So maternal lead exposure is usually assessed during the first prenatal visit. It's part of those initial labs. And obviously, if the mom lives in an area that there is minimal or no lead exposure, then the results will be fine. There's not much to follow up on. But if the mom lives someplace where there's more lead exposure, then this is something that will be followed up on. We do check babies for lead levels during their early pediatric visits. And then depending, as I said, on where they are, where they live, what the exposure is, they may need more follow-up or less follow-up. Developmental dysplasia of the hip. We discussed this already with the newborn. The story is the same, it hasn't changed. There are little ladies having a good time with their Pavlik harness. Again, they will wear the harness for several months to get that, the head of that acetabulum to grow into the hip joint. And these babies actually do, they do quite well. Congenital clubfoot may be positional, maybe congenital. There's still, can be a little bit of a debate on how this happens, but it's thought that it is multifactorial. So there's a genetic, remember with multifactorial conditions, there's a genetic composure and there's an environmental composure. So whether an environmental composure or an intrauterine environmental composure, but there are two pieces to it. So babies with clubfoot, there's much more to talk about with this, but again, you'll see this in peds. I just want you to have like the basic baseline information. These babies will have serial casting of the foot. It's initiated soon after birth. So they have their little casts on their either one foot or on both feet. And so that as they are growing, the foot grows into position. It grows the way that the bones and the ligaments should be positioned. So they will come in for successive casts. They're casted in such a way that it provides the structure for the foot to grow, but they have to be loose enough because this is a growing baby so that they can come in, they don't have to come in every week. But that's basically congenital foot.
I have a question on that with the multicasting. I mean, I haven't seen this in a long time, but when I was a kid, I remember seeing about like other kids with not casts, but like metal contraptions on the bottom of their legs. Is that this, or is that something else? Or
so was it more towards the foot or the ankle?
The calf down to the foot. Like I remember, seeing it just like it's like an exoskeleton for the bottom of the leg.
Yeah.
Metal braces that Forrest Gump wore.
Right. Exactly. Perfect. Thank you.
It can be for congenital foot, or I have a nephew that had serial casting, and I just remember once he went to the pediatrician and they did the next cast, and as I said, they make it a little bit loose because this is a growing baby, and he was a kicker. He's plays football now. He was a kicker, and he came home and he kicked the cast right off. I mean, they made it loose enough that he could grow into it. It just didn't anticipate. He just kicked it right off. As he got a little older and started to wear shoes, he had shoes for when he wasn't walking, but shoes that had a bar that held his feet in place. So yeah, there are various types of kind of braces, or depending on the extent of the club foot and how much of an angle needs to be adjusted. Yep.
Thanks.
But it allows the body to, it kind of grows into position, and it's certainly better than doing a surgery or something that's really invasive. Okay, so before we start respiratory, any questions about our neuromuscular kind of? Okay. So respiratory complications. We'll talk about TTN and meconium aspiration and laryngeal papillomas. I'm not going to cover PPHN because it is very complex, and we just don't see it as often as our technology and care and prenatal management have advanced. We just don't see it as often. So I'm not going to cover PPHN. All right, so transient tachypnea of the newborn. We talked about this a little bit when we talked about our C-section babies and how they would have some of that amniotic fluid retained in the pulmonary tissues, in the lung tissues. So TTN is due to a diminished absorption of fetal lung fluid. So usually due to cesarean birth, maybe that this baby was macrosomic as well. In a precipitous labor, remember that's that really rapid labor. So sometimes these babies are born so rapidly that they don't actually have enough time for that thoracic cavity squeeze to occur. Moms who have prolonged labor have the similar issue, but on the opposite end. They're in labor a long time. The babies don't have, they don't descend at a rapid enough pace to get that squeeze, and multiple gestation. So manifestations include tachypnea, grunting, flaring, retracting. So same GFR we've talked about, and tachypnea as we've talked about. Treatment is supportive. TTN is not, you're not looking at an infectious process here. We're not talking about a pneumonia. We're not talking about a pneumonitis, none of that. It's really just the excessive fluid that the body just needs a chance to manage. So our treatment is supportive. These babies might need an oxy hood. They might need chest PT. We talked about doing chest physiotherapy. They might need positional drainage. Sometimes they need a little suctioning. They usually do not, because it's mainly oxy hood, and CPT that they need. This typically resolves within 24 to 48 hours. Most babies who are born with TTN will go home with the mom. Okay, as long as they don't have any other issues. Occasionally they might be there another day, 72 hours, but usually within 24 to 48 hours, they're doing well. So what challenge might there be? You're taking care of a baby, let's say a baby that has TTN. What other system is impacted by this, or what else is impacted by this TTN? So let's say this is a full-term baby born by C-section because of cephalopelvic disproportion. So not a complicated case, just a CPD, C-section, everything went fine, but this baby now has TTN. So this would be a 72-hour length of stay, right? The baby was born, let's say the baby was born this morning at 9 o'clock. What other than respiratory are we handling? So we've got this baby under an oxy hood. We're going to do chest PT. What else do we need to manage for this baby? So Ruth, you said cold stress, right? Monitoring for thermoregulation.
Yeah.
What else do we need to do for this little person?
Well, if it's a macrosomia baby, big baby, the amount of glucose that this baby the baby would probably have increased insulin.
So, but what about if the baby's not macrosomic? Let's say it's just a CPD baby. I mean, along the lines of what you're thinking, but it's not a macrosomic. Would we still need to monitor that? So I'll give you a second to think about that. Palavina, you were saying something about fluid balance. I don't know where you are.
Yeah, I was just thinking because it absorbed so much fluid, there could be a chance of fluid and electrolyte imbalance, so circulatory system.
But the fluid is absorbed into the lung tissue. So it's amniotic fluid that's absorbed into the tissues, not into the vascular space. So it's not, right? It's in the tissues. But somehow I want what you said and what Ruth said to come together.
I'm sorry, you said that they can't, if it's not absorbed correctly, wouldn't it get absorbed somewhere like into the lungs? But you said no pneumonia, right?
So the lymphatic system is typically absorbed by the lymphatic system. So Simona, remember, this is not an infectious process because it's just amniotic fluid. So we're not, we typically don't have an issue with infection
I
here.
thought meconium. Sorry.
No. So we'll talk about that in a few minutes.
Yeah.
But remember, okay, so look at your manifestations.
Maybe delayed lung maturity.
So no, term baby.
Cardiovascular.
Typically we see TTN in our term babies, but look at your manifestations. How is this baby? How are you managing this baby's nutritional status? First of all, are you feeding this baby? This is what I'm trying to get you to think about. Are you feeding this baby? This baby has a respiratory rate of 75. Are you feeding this baby? This baby has a respiratory
Not, they
rate of
might
70.
aspirate.
No.
With
They might aspirate.
As soon as I say to you, the baby's tachypnic, no. Right there, no. Okay? The baby's retracting, the baby's flaring, no. I mean, the baby's under an oxy hood, so it would be clumsy. There are ways to do that, trust me, but that's not the issue. The thing is that this baby's an aspiration risk. Okay? So remember that anytime you have a baby that has a respiratory issue, the baby's an aspiration risk. You have to monitor the baby's nutritional status. And when I say nutritional status, I'm not just talking about feeds. I mean, I'm talking about even just basic hydration. So fluid and electrolytes, nutrition going in, and of course, the output. So Victoria, I know you had said something about diminished in and out eyes and nose, but that's on us to manage, right? So this is a baby that's that is in that has TTN, that is tachypnic. We can't feed this baby, so we have to figure out what are we doing with this baby. So what are our options for nutrition, hydration for this baby? So we could use IV fluids. Typically, these babies are not going to be on IV fluids long enough to put them on TPN. That would be an option, but these babies, because their lengths of stay and the course is rather short, we usually don't have to put them on TPN. So typically a baby like this, you would start on IV fluids, at least initially. So maybe do that for like the first few hours and see which way we're going. If this looks like it's going to take a while, then you may gavage tube feed the baby until the respiratory issues begin to resolve, and then you can start to feed this baby orally, to PO feed this baby, all right? Okay, so we have a baby that has a respiratory issue. We've figured out how we're managing our glycemias. Don't forget, you have to manage the thermoregulation, right? As I think Ruth had said, you don't want this baby to go into cold stress, okay? Because we've already got one compromised system here. We have to make sure that we keep the other two systems in balance.
A question about fluids. Is it enough fluid to worry about any kind of like CV pressure change? Like if it's going into the lymphatic system and getting dumped back into the circulatory system, is there anything there that we need to pay attention to or be concerned with?
It's not, in terms of volume, it's actually not a lot. So it's not going to compromise the cardiovascular system. I think what we have to be more careful about is the fluids that we're managing. So the IV fluids that we're giving and making sure that we're getting adequate output for what we're giving. Yeah. So questions about TTN?
So Professor, it's not like this baby doesn't know how to breathe, suck, and swallow. The baby could do it. It's just that he's having trouble with his breathing. That's all.
Right. We typically see this in term babies. So they have the neurological maturity to do suck, swallow, breathe. But with a respiratory rate of 75, it's just gonna be a mess. That baby will aspirate, yeah. Okay, so yesterday we talked about RDS, so respiratory distress syndrome. So how do the two compare? So how do they compare in terms of manifestations? So I'm going to go back to this one. How do they compare in terms of manifestations? Do you have tachypnea in one, the other, or both?
And I would say it's in one. It starts off different with respiratory distress syndrome.
So, but do you have tachypnea in RDS?
Yes.
Yeah.
And do you have tachypnea in TTN?
Yes.
So you have tachypnea in both, right? So they have that in common, okay? Do you have grunting, retracting, and flaring in both?
Yes.
Yes.
Or you can, right? You can have GFR in both. So you can have tachypnea in both. You can have GFR in both. Might you have a need for oxygen in one, the other, or both?
In the
Yes, we have
respiratory distress.
concentration.
So you can have a need for oxygen in both. All right. Which one are you more likely to, is a baby more likely to need ventilation support? So which one is a baby more likely to need support with pressure? With pressure. With RDS.
Yeah.
Pressure, RDS. Okay. So which, in terms of your patient populations, who are you more likely to see TTN with?
Some baby.
I mean, it's kind of right there. So you're more likely to see TTN with your full-term babies, right? Full-term babies, C-section babies. Who are you more likely to see RDS with?
Preemies.
Preterm babies, and who else? Okay, so I want you to leave a line there because we're going to fill that in a minute. Okay. What's your etiology here? What's causing your problem? What's causing the problem for TTN?
Amniotic fluid.
The reduced absorption of the amniotic fluid, right? Baby didn't get the squeeze on the way out of the baby. It wasn't a vaginal delivery, or it was a rapid vaginal delivery. So the baby has this retained lung fluid. What is your issue with RDS?
Lung immaturity. No.
What's your issue with RDS?
Well, as thermoregulation and the
Oxygen.
What's your main issue with RDS in one word?
Surfactant.
Surfactant. So, surfactant. So that is what's really your main issue. Okay, so now go back to who you're more likely to see RDS with. You told me preemies. And if surfactant is your main issue, that means whatever interferes with surfactant is going to cause your RDS. So who else?
Diabetes mom.
Your diabetic babies. Anything that interferes with surfactant production is more likely to give you an RDS baby. So you have to be able to distinguish between these two, because when the baby is in front of you, grunting, flaring, retracting, and tachypnic, you have to be able to make the distinction based on what you know of the history and what you know of this baby as to what you're looking at. All right? Because some of the things you need to do for TTN, you don't need to do for RDS and so on. All right? Some things you need to do for RDS, you don't need to do for TTN. Okay? All right, so questions about that before we talk about meconium aspiration?
Would there be testing to see how much surfactant the lungs have, or is it obvious to a healthcare provider when they're presenting with TTS versus RDS?
So
And so
TTN, we tend not to be as, I'm gonna say as aggressive, but you don't really do testing like in the tissues, but what you can do is a chest x-ray. So the way the chest x-ray appears, what you see on the chest x-ray, chest x-rays with RDS have a ground glass. Like if you take a glass and you break it and you kind of really grind down the glass, it has that appearance, as opposed to a TTN that doesn't have a ground glass. So the appearance on chest x-ray is pretty much the clinical manifestations, and the appearance on chest x-ray are your primary diagnostic tools for RDS. So if you have a baby that has TTN, you're looking at the clinical manifestations, you're looking at the history, mom's history, labor and delivery history, and say, okay, this baby more than likely is TTN. If it's resolving, you might not even get a chest x-ray. Baby looks like they're doing better. You're doing your chest PT, giving the baby some IV fluids, a little supplemental oxygen. Baby looks like they're getting better. You might not even need a chest x-ray. RDS, you'll definitely do a chest x-ray for. Okay.
Professor, so yesterday I know that like we learned the CPAC, continuous positive pressure thing, that treatment is for more like RDS than
RDS, because those, yeah, more for RDS.
thank you.
Because remember, surfactant is what's helping keep the alveoli open, and that pressure is about keeping the alveoli open. Okay. So, mechanical meconium aspiration syndrome, MAS. So before we even talk about this, a couple of things about meconium. So this is, as we talked about a couple of weeks ago, the baby's first stool. It is very sticky, tar, like it has a tar-like consistency, dark green, black, sticky. Now, when a baby is in utero, is meconium sterile? I think we had this conversation.
Yes, we said.
We did talk about this, right? Okay, so meconium is sterile. Now, it is sterile, but I want you to think about the consistency of it, okay? All right, so we'll put that on the side for just a moment. Okay, now, you have a baby in utero. Why might a baby, I'm gonna stop sharing for just a second so that I can see you. Why might a baby in utero, why might a baby release meconium in utero?
Is it stress?
So distress caused by what? So neonates, you said hypoxia. What might cause that kind of hypoxia? What do you think?
I mean, if the baby is postpartum, at some point the placenta starts detaching, right? So the
No,
baby,
not that it detaches, it starts to degenerate. So it just starts to like
yeah,
not work as well.
right? Yeah, so the baby doesn't get enough oxygen.
So yes, that will do it. Now, so again, same story. You have this baby that's in distress. What are you seeing on your strips? What are you seeing if this baby, mom comes in for an NST? What are you seeing?
Late deceleration, right?
Late decelerations, yes. Now, a baby, if the mom was smoking, because I saw smoking in there, if the mom, it was smoking, like if she's smoking right throughout the pregnancy, you might not get, typically you won't get meconium aspiration, because as weird as it sounds, the baby has somewhat acclimated to that vasoconstricted condition. So you might get a baby that's SGA, you might get a baby that's IUGR. But you might not really get a meconium aspiration. You might see some late decelerations, like if the placenta is already vasoconstricted from the smoking, and let's say the mom is having a very stressful morning and she smokes like 3 cigarettes, you might see some late decelerations right then, right? But in general, you're not going to see meconium from that. Absolutely, from substance abuse, you can. What else might put a baby into sudden distress?
Placenta previa and abruption.
Abruption, definitely an abruption. Preeclampsia would have to be severe, but we tend to see this more with, I'm sorry, I'm trying to read and talk at the same time. Abruption, we tend to see this with substance abuse. Okay, so you have a mom that goes into, you have a fetus that has sudden, oh no, I'm sorry, let me go back and just finish this conversation. So you have a fetus that has, either has a sudden episode of distress, or you have a fetus that has had repeated incidences of distress. Now, when the body is, when the fetus is in distress like that, one of the things that can happen is that the fetus can release meconium. The fetus can release meconium. So let's say you have a fetus that, today is December 1st. This is a fetus that has been in distress, let's say over the past week or 10 days. So has been releasing small amounts of meconium. And so let's say over the last week. So mom presents at the hospital today with ruptured membranes. What color is her amniotic fluid?
Greenish.
So greenish, like what kind of greenish?
Dark.
So, I mean, is it like lime green, or is it avocado green, or is it Kelly green? Like
Nice forest pine green. Something.
so it might not be as dark, but it will be definitely a distinct green. But what do you think about the consistency?
More viscous, yeah.
So it will be, because there has been the release of meconium, multiple releases of meconium. Okay, so what about the mom so it'll be distinctly green and thicker, right? So remember, when you're doing your code assessment, this is the stuff that you're looking at, okay? So it would it have an odor, or would it just smell like amniotic fluid?
It would probably have an odor.
Odor.
Why would it have an odor?
Oh, maybe not, because it is sterile.
It is sterile, yeah, but.
Right,
The
okay.
odor.
So what about the mom who had a sudden, whatever happened, a sudden incidence of this fetus had a sudden incidence of distress during the night. Mom presents this morning, so there was one release of meconium. What would you tell me about the amniotic fluid consistency?
It wouldn't be too altered.
So it would be thinner than the previous patient that we talked about, more like typical normal amniotic fluid. And what do you think about the color?
I mean, you'll still have, I think, some discoloration, but it wouldn't be as dark as pronounced.
So it would be more of a greenish or a greenish tinge to it, right? So just looking at the amniotic fluid tells you a lot, right? So this is what I'm saying to you. You have to apply what you know to what you're seeing, okay? So merely the way you're looking at the fluid tells you a lot, and analyzing just what you're seeing gives you an indication of what went on here. How did we get to this point, okay? All right. So we have this baby who's had distress. Meconium in the amniotic fluid. We've got late decelerations on our strip, non-reassuring fetal heart tracing, and category 3 tracing. Now, depending on the amount of meconium in the amniotic fluid when it was released, that's going to depend on a lot of what we do. But we know, okay, this mom is delivering vaginally. There is meconium in the amniotic fluid, whether it's green tinged or it is what we call pea soup amniotic fluid. It's thicker and is distinctly green. So depending on whichever one it is, what we need to do, remember when the head is delivered, what is the first thing that baby is going to do? It's going to take a deep breath.
Yeah.
Now, what is right there? All of this amniotic fluid. We don't want this baby aspirating all of that, okay? So typically what we do is upon delivery of the head, we suction below the vocal cords. So you have to be ready, you have to have the equipment ready, you have to have everything perfectly set up. So as soon as the head comes out, but before the baby can breathe, that tube has to be dropped below the vocal cords because you want to get down deep, get all of that meconium out so that it doesn't get into the lungs.
So that would be the first thing we do. We wouldn't do anything else. We would just suction below the vocal, not the nasal.
The thing is you're getting below the vocal cords, right? So remember, it's not, you have to get in and you're getting what's as far down as possible and then out. So you can do that through the nose. We usually do it through the mouth because it's just easier while the head is on the perineum. This is like in the split second before the body comes out, you have to tell the mom, stop pushing while the head is out. You're doing this. So it's like, it's very quick. It's got to be very, very quick. Okay. Then you can, you will do more suctioning after, but you've got to get as much as the lower fluid out before it gets into the lungs. All right.
Professor, question. Supposedly a mom arrives at the hospital and their water broke a few hours before. You can only ask her the color of the amniotic fluid.
You'll see it.
Swabbing?
Yes. And when you do your sterile vaginal exam, right, you'll see it.
Okay. I mean, it keeps staying. It remains staying. Oh, okay.
So remember, amniotic fluid the membranes rupture. It's not like all the amniotic fluid comes out whoosh in one.
Okay.
No, right? So you can have it can drip, it can gush out, but there's still going to be some in there. Okay. There's still going to be some in there.
Okay.
Okay. So the reason I put a star there is that is what we still do in practice, even though there is some current research that says, well, whether you suction below the cords or not doesn't make a difference, but we still do it in practice because when the amniotic fluid gets below the vocal cords, it's really bad. So, we'll talk about that in a minute, but that's why that star is there. Now, so those are our babies that, okay, so that's one scenario, but what about the babies the first baby we talked about, the one that's been releasing meconium for a week? So that means that in utero, while the baby was floating and doing its breathing movements, that baby was already breathing in and out amniotic fluid that has meconium in it. So even after the delivery, even if we do this suctioning below the vocal cords after the delivery, we've already got amniotic fluid, this meconium stained amniotic fluid everywhere. Okay, so the severity, so again, the severity and the management really depends on the amount of amniotic fluid and when it was released. All right, so that one time, okay, the baby went into distress, let's say mom abrupted, fetus went into distress, released meconium, and we're having this quick vaginal delivery, suction below the vocal cords on the perineum. That's one scenario. But the one that has been having this ongoing, that's going to be a more complicated meconium aspiration syndrome to manage. All right. So amniotic fluid, remember, is the consistency of water. It's thin. So really it can be absorbed into the lymphatic system fairly quickly, fairly easily. But when you have meconium mixed into the amniotic fluid, now you have a totally different fluid. Okay, you have something that has particulate matter. It has things in it that are going to irritate the lung tissue. So this is where you get a chemical pneumonitis. It's not, remember that the meconium was sterile, so it's not so much, even though I know you're thinking, but it's stool, it's got to be infected. It's sterile. So the issue is not so much that it's infectious, but that it's extremely irritating.
So Professor, essentially it's just a change in consistency. Like it's not thin, it's thick, it's a little bit thicker now. And the baby is—
But remember, it can be thin if you only had the one meconium exposure, right? So it's not just the consistency, it's what's in it. It's the makeup of meconium is irritating to the lung tissue.
How's the interplay between the meconium and the surfactant? Like for somebody that, like for a fetus that's been releasing over time, so there's a good amount in there. I mean, now you've got the sticky in there, and I get the pneumonia. I mean, that's obvious, but it's like, what do you do to counteract that? Because that's just crazy.
Yeah. So, well, I'll come to that. I'll read that in. So what you have actually is this chemical pneumonitis. It's very irritating to the lung tissue. You can have obstruction. Again, meconium is thick. If you have, some particulate matter, you can have some kind of like small globs of it that can cause obstruction. So it can obstruct in the airway. You can have air trapping because you have like a little, even a speck of meconium, but the air is trapped beneath it and the meconium is blocking the airway, so you can have air trapping. So this can be really, really, these babies can be really complex to manage. So this baby, this is a meconium aspiration baby. So I don't know how well you can see this, have this arrow here on the cord. This meconium is actually kind of, like almost mustard colored, but you might not be able to tell, but this is actually amniotic fluid. It's thick. This is a baby that was releasing meconium over time. So this is more the consistency of what we kind of call pea soup amniotic fluid. I apologize to those of you who like pea soup. You will find that nurses, we always we use a lot of descriptions that have to do, I don't know what's about this, but it's probably some psychology involved here that like have analogies to food. It's kind of weird, but anyway. So this kid has this thick meconium, not even tinge, but this thick meconium amniotic fluid in the lungs. So obviously this baby is being mechanically ventilated and will this kid ended up on a respirator, on a ventilator. Okay. Now, what would you guess about this baby's gestational age? And tell me what gave you the clue. What are you best basing your guess on?
I think this baby's full term. He looks like he has a little subcutaneous fat. He looks a little healthy.
The creases on the bottom of the foot.
So the size, the palmar creases, what else?
Flexion, like he's flexed.
Flexion, the left hand is fully fisted. You can see even the creases and folds on the hand. So you guys don't need me. Look at this. This is what I'm saying. You got to look at your patient, but look at, all I had to do is ask the question, right? So you have to start doing that. Like, look at this independently without me prodding you and saying, oh, this is a term baby, right? This is a term baby. This baby looks like a term baby. So anyway, this baby will need mechanical ventilation. It can take a while for these babies to resolve this. The lung tissue will clear this in a somewhat similar manner to how the body resolves a pneumonia, somewhat similar, but it takes time. We have a newborn baby who's got a lot of figuring out. The body, this newborn body has a lot of figuring out of how to function to do. And now has this to contend with as well. Now, in terms of the surfactant, it's good that this baby has a good amount of surfactant because this baby is able to keep the alveoli open, albeit that they have meconium in there, but at least the baby is able to do that to contribute to that work of breathing. You don't have the issue of alveoli collapsing. So a baby that's able to do that, a baby that has sufficient surfactant, is going to need less respiratory support.
This would be infinitely worse for a preemie that has
yes.
a certificate or a certificate. Yeah.
Yes, because then you can have the the RDS on top of it, or a diabetic baby.
And I would imagine that this is somewhat common.
It's not, but it's not. I wouldn't say it's uncommon, but I wouldn't say it's fairly common.
Right.
Yeah. So we see more of the one-time, so to speak, release of meconium. We see that more than we see these. We tend to see these with chronic kind of situations like, ongoing substance abuse and that sort of thing. So, but again, looking at your histories, you have to, be thinking ahead, of what might happen at the delivery. So if you're working with a mom who has a history of substance abuse, you have to have this in mind, that this could happen at some point during the pregnancy. This is a risk. She could abrupt. She could, you have to have these things in mind of what could happen.
This is also another case for those doctors that'll sit and let a post-term go for a while. This is another risk that's going to happen there. So yeah, it's just, I don't know why you would do that.
Yeah. I mean, it's a philosophical difference. Some people think, well, it's true. The body is an amazing, I always say it's an amazing machine, has an incredible ability to heal itself and to do all kinds of things. But there's sometimes that, we have the capability, we have the equipment, we have the hospitals, we have, I understand 200-300 years ago when we didn't have these things, but we do. So, I don't know. Okay. Diaphragmatic hernia. Oops. Okay. When in utero, early during the pregnancy, when the diaphragm is forming, it actually forms kind of from side to side. like that, right? If it doesn't fuse and there is a hole, so remember your anatomy, if it doesn't fuse and there's a hole, the abdominal contents, the bowel, can kind of wiggle out into the thoracic cavity. So they're lighter, they can just come out into the thoracic cavity. So that is really what diaphragmatic hernia is. It's a herniation in the diaphragm. Now, if the herniation is large enough and enough of the bowel ascends into the thoracic cavity, it will take up space. And this lung, the lung on that side, it usually happens on the left side, will not develop because you have the bowel is there. So the lung has no place to grow. So it doesn't. Okay. So you can have, so for instance, if this baby, when this baby is born, this will be the sizes of the lungs. So this baby might have the corrective surgery to replace this bowel into the abdominal cavity. This left lung is not all of a sudden going to grow. This is it. This is it. Okay. So that left lung will be hypoplastic, will be smaller, right? Let me just check the check box. So it's usually, yes, it's usually on the left side. Remember that herniations can happen in the skin, in muscle, in the diaphragm. Herniations can happen in a variety of places, not always on the skin. Okay. What is, before we even come to that, what is a major concern when this baby is born? What's a major concern when this baby is born?
Adequate respiration.
Respiratory.
So, because what's your concern about the respirations?
There's not enough room for lung because it's pushed up, as you just say.
Well, it's pushed up on one side. The baby does have this right lung, right? So yes, the baby has like 1.5, so to speak, instead of 2 lungs.
Mm-hmm.
But I also want you to think about how long does it take before you, I can't remember if I mentioned this or not, newborn baby, how long before you hear bowel sounds?
Usually the first day, after a few hours, they should have like within 24 hours. I don't remember if it's the urine or the...
No, but I'm not talking about meconium, I'm talking about bowel sounds. Because remember, when you're hearing bowel sounds, you're hearing air throughout the bowel, right? That's what you're hearing. You should hear bowel sounds within an hour. Within an hour, you will hear bowel sounds. But do you want this bowel to fill with air?
Close to the heart, and no.
So remember, once air starts to get into the bowel, it's going to start to inflate, right? So if this bowel is allowed to inflate, it will further compress this lung and it can cause a pneumomediastinum. It can actually push everything to the right. So it will push the lung up and over, and it will also push the heart over. So these babies have to be really, really carefully managed when they come in. So that's what you're seeing here, right? So bowel, this is the large intestine here. This is the diaphragm. Look at all of this bowel in the thoracic cavity. So if this baby was admitted to your nursery, remember your assessment, right? First step of the nursing process, always. One of the first things you're listening to your baby for, you want to hear clear breath sounds bilaterally, right? You did health assessment last semester. You should hear clear vowel sounds throughout. Baby with the diaphragmatic hernia, what are you hearing when you're listening to the left lung? When you're listening here, what are you hearing?
Probably the heart.
Nothing.
What are you hearing here? You're hearing bowel, you will hear bowel sounds. You hear, I mean, you shouldn't hear bowel sounds up here. There's no way you should be hearing bowel sounds up here, right? That's what you're hearing. You know something's wrong, okay? But you don't even want it to get to that point. So think about if you're hearing bowel sounds here, instead of hearing the heart where you should hear it, you're going to hear the heart over here on the right side, shifted. Everything is going to be shifted and pushed because of this bowel.
And won't that differ pending where the penetration is? Like, could it be that it's like more towards the heart and it just shoves the heart more back and left? You know,
the thing is that the herniation, usually it occurs on the left. What really makes the difference is how much bowel it sends into, how much bowel is in the thoracic cavity, and whether or not it aerates. So when these babies are born, it is up to us to make sure that that bowel does not aerate. So the first thing we have to do is make sure that bowel remains decompressed. First thing you have to do. You want that bowel decompressed. You cannot let air get into that bowel, okay? So these babies will go to surgery for surgical correction to put that, the abdominal contents where they belong and to close off the diaphragm. However, the first thing you want to do is make sure if baby comes in, that bowel is decompressed. So an OG tube to suction. You don't want any air in that bowel, all right? You don't want to bag these babies. You don't want any air in that bowel. You want that bowel decompressed as flat as possible. So that you can get this baby to surgery. It makes the surgery easier. And remember, if the bowel does not aerate, you're not going to have all of that shifting in the thoracic cavity.
So the surgery will happen very soon.
Yes.
Oh.
Professor?
Yes.
This is related yesterday, your lecture that the preemie babies, you give it to them like constant oxygen, that you said you have to open the OG tube because otherwise they're going to be filling up the bubble in their stomach. Is that related to this?
It's the same principle. It's the same principle. We'll talk about something else in a few minutes. The same principle. It's just, if you ever think about, it's happened to everybody where you either something you had to eat or you didn't eat on time or whatever, and you feel bloated, that horrible discomfort of abdominal distension. That's what you're trying to prevent.
Okay.
Yeah, that's what you're trying to prevent.
Professor, so you would put a tube down their throat all the way into their bowel and then suck
to the stomach, just to the stomach. To the stomach is sufficient because the air is going to, so think about it, air rises. If you put the tube down and the tube is up, the air is going to come up and out.
Okay.
All right, so just give me a second to catch up here. So you might not need to give this baby extra oxygen. It all depends on how functional is that full lung, how functional is that partial lung. The question is how much did this lung develop? So if this is working at 100%, and granted you only have half a lung here, but it's working at 100%, that might be enough. That might be enough. But if it's hypoplastic and it really hasn't developed very well, then the baby might need more respiratory support. If the baby is 36 weeks, doesn't quite have enough surfactant, then the baby's gonna need more support. The baby's 36 weeks and diabetic mom, baby's gonna need more. So, it's those little things that can factor into how much, okay? But I think you understand the principles of what's happening here anatomically, what we need to do and what we need to make sure it does not happen. Okay. Now, what other condition does this make you think of? And I know it's probably just like a complete blur, but Jinhee, you mentioned what I said about babies that are on CPAP and having the OG tube open to air. But what something else that we talked about, I'm just going to look for the slide. Something else that we've talked about.
The one where the bowels are born outside and you have to cover them with saline.
So.
Saline gauze.
And so.
That was two separate ones.
No, it's okay. That's the one that we were talking about,
one
gastroschisis.
outside.
Right.
Yeah, one with the
right. So gastroschisis, exactly, Palavinas, gastroschisis. Same principle, you need to do the same thing. Except with gastroschisis, obviously you have to cover the bowel, and we've talked about how you would do that. But you don't want this bowel. You see this bowel is full of air, right? This is going to be much harder to get this bowel into the abdominal cavity. Much, much harder. So whose responsibility is that? That's on us. To do everything we can to keep that bowel decompressed. So
I thought it was a series of surgeries before.
It is a series of surgeries, but I'm talking about as soon as the baby is born. You don't want that to happen. You don't want that bowel full of air like that. That bowel is full of air. You don't even want that to happen. So as soon as the baby is born, even as we are, and I know it's always your ABCs, but even as you are stabilizing the respiratory status, you have to think, as I'm stabilizing the respiratory status, everything I'm doing to support the respiratory status is going to cause air to get into the bowel. So even as that is happening, I've got to get that tube down to decompress that bowel. This is going to be really hard now to get this, when this baby is taken to surgery, all of this air has to be removed from the bowel.
Professor, question.
That takes time. You can't just just suck it all out and then push all that bowel in. You can't, you can't manipulate the intestine like that. It has to be gradual. Questions?
Yes, I saw a documentary somewhere, Netflix or whatever, about this, and they actually put all the intestine in a bag, suspending in the air, and slowly it goes inside.
I think I did. Didn't I show that on the? Yeah. That's how it's done.
But it
takes time. It's gradual. It is gradual. But the thing is, you don't want the bowel to expand.
Yeah.
If the bowel is full of air, even putting it in the casing is much more difficult.
Do we have an ostomy to avoid this during this kind of a case?
I'm sorry, a what?
An ostomy so that we can take care of, the baby's got to feed, and this is going to affect digestion. If you can't use your intestines, so
these babies are on TPN, on Hyperal for a long time. These babies usually end up with the central line, and they need hyperalimentation for several weeks because that process takes several weeks. The problem with these cases is that the bowel has been so manipulated. I mean, even you try not to handle it or to do as little as possible, but you still have to handle it. The bowel has been so manipulated that they tend to have a lot of digestive issues even when they start feeding. So they're capable of doing the work, the swallowing, the sucking, the coordinate. They don't have a problem with that. Down to the esophagus, down to the stomach, life is wonderful. But once it hits that bowel that's been so manipulated, they have a lot of malabsorption issues and just a lot of nutritional, in terms of how the gut actually works, how that bowel works and absorbs. Yeah, they have a lot of nutritional problems because of that.
sorry, I know you're going into this later, but is there like a memory to like the large intestine? And what I mean by that is like if you have a cable and you want to do it, like it might want to recoil back to its original shape. Now, this hasn't had an original shape yet.
Right.
So is that surgery that is, directing it the way that it needs to go inside, combination of both, or how does that work?
With these gastroschisis babies, it kind of is. I mean, when the bowel is placed into the casing, the surgeons usually try to place it in such a way that as they are advancing it in, it's advancing in order, in the way it would be, and then the bowel kind of acclimate. But even that is a whole manipulative process for the bowel. Yeah, it takes weeks for these things to, yeah.
But Professor, you will continue the suctioning during all these surgeries that the bowel is being placed back inside the abdominal cavity.
So definitely while the surgeries are being done, because you don't want it to expand. Yeah. Yeah. Now, normally, the bowel has air in it. Unfortunately for these babies, they don't even have the capacity for that. They barely have capacity for the bowel to get back into the cavity. And then when that bowel starts to expand with air, they have a hard time, these little ones. They really have a hard time. Gastroschisis. Okay, so going back to our omphalocele, see how much fun stuff we have to pass through. I'm going back to our diaphragmatic hernia. You can see how a lot of the principles are the same. You just have to think about, okay, in this situation, how does it apply, right? Because decompressing the bowel is decompressing the bowel. So whether you're doing that for diaphragmatic hernia, you're doing it for gastroschisis, you're still doing the same thing for the same basic reason, but it impacts the case a little bit differently, okay? So these babies, again, they will do fairly well. If they can get this surgery, we get this surgery done early, and depending on the condition of this lung, how well developed it is, these babies they tend not to have GI problems. They tend not to have digestive issues. What may be challenging for them is the respiratory status because of this lung development. As opposed to the gastroschisis babies, their problems are going to be bowel. Okay, so I'm going to drink a little tea, and I'm going to have you look at this picture and tell me what you see.
There is what is the esophagus? It's not tight.
Is that a fistula?
What is it?
I'm laughing at you asking me what it is.
Okay, it's a fistula.
I'm asking you what it is, and you're telling me.
It looks like a fistula because the esophagus seems to be, the top part of the esophagus seems to have stopped, and the continuation of the esophagus that's supposed to be connected is actually connected to the
trachea.
Yes, to the trachea. So that's definitely a fistula.
So this baby has two things. This baby has an esophageal atresia. The esophagus stops, ends in a blind pouch, and the lower esophagus is fistulated onto the trachea. So TEF and EA, tracheoesophageal fistula and esophageal atresia. So there are several forms of TEF and EA, but let's start with the proper anatomy. And I want you to just think about what you know about both systems, respiratory and GI, and just basic things, and you'll be able to really think through what the issues are here. So if you have, normally the baby will breathe, the air comes down the trachea, right main stem bronchus, left, and goes into lungs, right? Baby eats, food comes down the esophagus, goes into the stomach. Okay, here, if this baby, when this baby feeds, what happens? What happens?
Doesn't feed. It doesn't feed. It doesn't go.
It does feed.
It will hold the stuff.
Where? Where?
It's not going to feed as much, right? So once this pouch is full, then what happens?
It's going to come up.
So is come up how? So now the baby is still sucking, right? Baby is still sucking, but now the pouch is full. The feeding, is the baby vomiting, or is the feeding just kind of coming back out?
I mean, they'll aspirate on it. It'll come up and then go straight down the trachea.
Well, it might not aspirate, right? Because you are going to be there to catch it, right? You're going to catch it. It's not going to happen. But what happens is once the pouch is full, there's nowhere for the rest of the feeding to go. The baby is still hungry.
Exactly.
The baby is still hungry, right? So the baby still wants to eat, but you will see again, a lot of these TEF and EA diagnoses are made by the nurses feeding the baby, because you see what's happening or what's not happening. Now, this same baby, the baby breathes. Where is the air going?
In the stomach.
So not all of it.
Also.
Not all of it though, right? So the air goes into the lungs, but some of this air is blowing into the stomach, right? So what does this baby's abdomen feel like?
Balloon. Swollen.
Balloon.
Balloon, yeah.
Tight, it's bloated. So this baby is uncomfortable because it's got this bloated stomach, but the baby's hungry. It's trying to feed, but the feeding isn't quite doing what it's supposed to do. So on several levels, this baby is not happy. Okay? Is not happy, right? So you just have to think through what is happening here. Now, there are a couple of different types, and I will show you those. But do you remember the first day, I think it was the first or second day of classes, that I showed you that that chart with the sensitive periods of prenatal development, and it had like the early weeks. So TEF developed, this happens in the 4th week of pregnancy. She might not even know she's pregnant yet, and she's already got a baby with a TE fistula, right? Or an esophageal atresia. So this happens really very early. Okay, now we talked about this one. This one is very similar, but I want to talk about this one. This is the one that you're concerned about. What happens when this baby feeds? Some of it will go to the lungs. This baby's going to aspirate. Some of it will make its way back into the lower esophagus and into the stomach, a small amount. Some of the air that this baby is breathing is going to make its way into the stomach. So this baby's getting a small amount of nutrition, but they are getting air, so they will have a distended abdomen, and this baby is choking with every feed, with every suck and swallow.
It's also the less pressure path, so most things will go that way. Like the trachea is held open, whereas the esophagus is closed until stuff goes into it.
Right.
It's naturally going to go foot on it.
So again, this, as I'm saying, these are very often diagnoses that we make. This can be seen on ultrasound, but if you have a mom that doesn't come in, if you're working someplace that has limited ultrasound services, and so you really save those for the babies that you know have anomalies, or you might be someplace that the ultrasound tech and their equipment, they come once a week and you only see the really high risk people. So there are cases that, I mean, I've taken care of plenty of these kids that right here in New York City or in other major cities, that the mom had prenatal care, was, in good health and so on. And we didn't know until these babies were in the nursery. Okay. So there are quite a few. I'm going to give you a chance to kind of look at this and see that there are several different types. So again, you might see it on ultrasound. Again, it's just going to depend on whether or not she comes in for ultrasounds. You get the ultrasounds, the quality of the ultrasounds.
It's the atresia was the one you would want to have if you had to deal with one.
I'm sorry, say that again.
The third one or the second one on the bottom, it looks like the easiest one to remedy.
Yeah, just attach this, right? Yeah, but these can be pretty problematic, like this one. I mean, everything this baby feeds is going straight into the lungs. So, so that is TE fistula esophageal atresia. Now, other than ultrasound, what in the patient's prenatal history is a tip off that this is what you're looking at?
Maybe teratogens?
So this can result from teratogens, yes. But I mean, something definite in the prenatal history. So mom comes in, and this is one of the things that's written in her chart. She has it's funny because you're several of you are like you're near it. Okay, so Jinhee, you're saying amniotic fluid, and Tenzin, you're saying amniotic fluid. Tell me more about this amniotic fluid.
The fetus, right? We need to be concerned. We will see about the lung maturity if you look at amniotic fluid. We can
but we're looking at mainly, but how does that factor into the TE fistula though?
TE fistula. If there is TE fistula developing on the week 4, right? When we will check the amniotic fluid, we will see there will be a less amniotic fluid because of the immature lung.
Or it's like a mother had a diabetic mother. They have a problem with polyamniotic problem. So maybe by accident, baby had a drink their own. I don't know. It's like too much amniotic.
So you guys are you're in the vicinity. I just need you to come closer. Simona, you were saying something about oligo?
We said that the amniotic fluid for 90%, 95% is urine. If this baby is not like drinking.
But if there's, okay, so I see a lot of things about amniotic fluid. I want you to think it through. Prenatally, what is the baby doing with amniotic fluid? Baby's breathing it in and out, right? Bathing the lungs, making breathing movements. Baby is their musculoskeletal system moving within the buoyancy of the amniotic fluid. What else is this baby supposed to be doing?
Making its own insulin and secreting it? No?
No, about the
Swallowing.
amniotic fluid.
Swallowing it. And
Baby
like
should be
going through the system.
swallowing it. So if you have a baby that has an esophageal atresia, how does that impact your amniotic fluid?
Reduce.
Gonna make a more
Polyamniotic.
Is it going to make it more or is it going to make it less?
more
Less.
more because they're gonna make a more pee because they drink more. They
No,
pee more, no?
they will drink less.
So
Go
if you're
absorb fat.
drinking more,
It
if
goes-
you're drinking more, so think about everything has to be in balance here. If you're drinking more and it's going into this pouch, what happens when the pouch is full?
You can't have it back out.
Okay, and then you drink some more and the pouch is full, and you drink some more and the pouch is full. What happens to the volume?
Increases.
It what?
Increases.
No,
Up
it'll
or down? I'm sorry, I didn't hear you, Simona. Up or down?
Increases. I mean,
Increases. It increases.
Yeah.
It's going to build up because it's not going anywhere.
Mm.
It's going into a
Okay.
pouch.
so polyodrome instead of oligodrome.
So if a mom has polyhydramnios, you should be thinking about that, right? As opposed to oligohydramnios. You have to think about what the function is and how this factors into which body system of the fetus does this factor into.
I have a question. I'm not quite following that increase, because if it's not going through the bowels and it's not getting absorbed through the bowels, that's less that's getting processed by the kidneys, right?
So it's backing up. It didn't even get that far.
Well, right. So how is it producing more if it's not processing more, right? Like, I mean, I kind of get it with the atresia double fistula because there's at least some getting down there. I just don't get it.
But
Like,
it's
so it's only
still-
processing, the kidneys are processing what's coming in through the uterus and the placenta and the bloodstream. And so it's producing its urine from that. But with the other part of the digestive system missing, I'm not seeing how it's producing more. That's where I'm getting lost.
No, it's not produced. So it's producing through the kidneys, but it's not being consumed. That's what's backing up. It's not being
that's
consumed.
More.
But that just gets released back out anyways.
But there should be a balance, right? So the baby should be swallowing and it's going through the system and the baby's making urine.
Yes.
So there should be a balance, but here the baby is swallowing and it's just coming back out, but the baby is still making, producing urine because of what the fluid, what it's getting through the
Lungs.
umbilical cord.
Oh,
I
okay.
just realized what time it is, through the umbilical cord.
I got it. Thank you.
Okay.
Professor, how do these babies survive in the uterus? I mean, it just seems like, I don't know, it just seems like this would just not work. I mean, aren't they like, well, I guess there's fluid in their lungs anyway. That's why they're okay in the uterus. Okay, okay. I'm sorry. My head is just spinning right now.
It's a lot. All right. So, okay. So that's TE fistula. Let me just see if I just realized what time it is. So we can take a break. Yes, the power. We will, so we talked about neuromuscular things. We talked about some respiratory things. We talked about some respiratory and GI, and then GI. All right, so we'll do cardiac after the break. Okay, so let's see, it's 10 to, we'll come back at 10 after. Okay. All right. Totally lost track of time there.